We do some more cases. I don't know if it'll take up the entire time, but we'll see. And what we're going to do is we're going to immediately go into the test and get that done, get it done before lunch, and then you can have the whole afternoon free, and we just have to get back here for 6 o'clock. So anyway, who wants to look at this one? Anybody? What kind of scan is this? It's a bleeding scan. And is there any bleeding? Yes, no. Where? What's this? No. If there was another kidney, try to be another one over here. Also, this is the aortic bifurcation right here. Kidneys are right here. There's the kidney. So, pardon? No, it's this. That's how much they're bleeding. It's that much. And so they went to an angiogram, and we saw this. So this is an early image, and this is a late image. So what do you think this is and what's happening? This is this. Okay, there may be angiodysplasia. Well, maybe. What is angiodysplasia is usually where? Colon. Okay, first, this isn't colon. Second, where in the colon usually does angiodysplasia show up? Most commonly. It's cecum. So that would usually be off the inferior mesenteric artery. I mean, it's over here. It can be off of, the superior mesenteric artery over in the corner. But this is small bowel with a big blood vessel going down, and yes, an early draining vein. And on the late image, there's the bleeding. So this really looks more like a tumor. If this was the liver, it would look more like a tumor. And that's exactly what this is. This is a small bowel tumor. This is a GIST tumor with ulceration and bleeding. So this went to resection. Okay, 79-year-old male with acute right flank pain, and this is the non-contrast CT and the contrast CT. And there is a little mark there, and it's -9 Hounsfield units. It's another angiomyolipoma with bleeding, and you can't see it at all here, but it's in there, and here it is, all the bleeding, and probably have another one on the other side. So there's the. So this patient went was from another hospital, and they had this arteriogram, and you can see the shape of the kidney. The kidney is squashed from all the blood, but here's an aneurysm right here. And this is something. What do you think this is? Has nothing to do with the reason, the pathology. This is what? Yeah, exactly. This is a iatrogenic dissection this is an earlier arteriogram. This was done at another hospital. And see where the catheter is? It's right there. So that was a dissection caused by the first arteriogram. So but if it's not flow limiting and you can forget about it and it'll usually heal. So anyway, they actually had done an embolization on this patient and they had missed it. So we ended up doing it again, and after we embolized it, it was gone. Okay, how about this one? Dissection. So aortic arch and all the way down superior mesenteric artery, or I don't know if that's superior mesenteric or celiac. It's probably celiac. And then it goes up, and then there's a dissection flap going out into the vessel. So the arteriogram, here's what it looked like. So you can see a dissection starting past the origin of the left subclavian, and then big dilated, you can see the dissection flap. And actually this was treated with a endograft. This was done back in the day when we used to have to make the endografts ourselves. So we actually took surgical graft material, put June Turco Z stents in it, and then used sutures to pull this into a delivery sheath. And then once that was deployed, there's the result. And no more. And nice, the dissections is well sealed, and you can actually see much better perfusion distally now that once you seal the flap, a lot of times the lumen, the false lumen will close down somewhat, and you'll get better perfusion. Okay. This is a post-op patient. I don't know what was post-op from, but there's another real extra bright spot in there that isn't supposed to be there. And there's this pseudoaneurysm coming off a branch of the superior mesenteric artery, catheterization of that branch, and filling of the aneurysm with coils to get rid of that. Now this was an interesting case. This is a patient that had a bladder resection, has an ileoconduit down here you don't see, and they have what we call retrograde nephroureteral tubes. So they basically have tubes coming in the conduit, going up the ureters and into the kidney. And this patient was having massive intermittent hematuria, and you can see, on a tube study, we inject the tube and there's blood clot in the whole left collecting system up in here. So we did a arteriogram. Is there some bleeding in the kidney? Well, we didn't see any. It's difficult to tell because of the contrast in the intestine. However, anybody have any idea where the bleeding is from? This is uncommon, but I've probably seen at least 5 or 6 of these cases now. Sorry, it has nothing to do with the bowel. It has to do with the fact that the person has a stent. And when they do a resection, they do an ileoconduit. What do they have to do? They have to dissect out the ureter, pull it across to the other side, so they can anastomose it so it comes out one ostomy, right? Well, when they do that, where does this ureter have to lie? It has to lie, and they end up lying right across the iliac artery on that side. So a person that has a chronically placed stent occasionally can have an interesting problem. And what it is, so here is an arteriogram that was done, and we didn't see anything. So what we did in this image is we took the tube out, the tube that was up into the left kidney, over a guide wire. And it's hard to see, but right here, that's blood coming right out of the iliac artery into the ureter, which of course at this point now there's blood squirting out the side of the patient because it's just filling the conduit. So we put the tube back in and measured it and placed a stent graft across where and then took the tube back out again, and there was no more bleeding. So now this is, I've seen this, enough times that if I even hear about this, I know what I'm looking for. I don't even bother looking in the kidney for a case. I had another one that we did that angiogram, looked at the kidney, and the kidney had a tumor in it. Oh, it must be the tumor that was bleeding. No, it was this was the situation. So, all right, sometimes we cause our own problems, and or even better yet, it's cardiology's problem and we have to fix it. So what's going on here? What's happening in this groin? Pseudoaneurysm from the puncture, from an arteriogram. So you see these, usually they're diagnosed because you get a big hematoma and you get ultrasound, and you'll see it with an ultrasound. And and then what you'll do is you take a needle, stick it in there. If it's hopefully it's a narrow neck, and you inject TPA, and then you can clot this is already after it's been clotted with TPA. So you can use that and carefully watch it under ultrasound and treat these. You do need to look at them again the next day, always, because sometimes they do recannulate, and you can just do TPA again. So, or excuse me, not TPA, I'm thrombin. Excuse me, I don't want to open it, I want to close it. So we used a thrombin injection, and it does do a very good job. So here's another, I'm just using some extra cases I had under the pulmonary embolism category. This was a person that had an esophagectomy. Here's the CT. You can see large thrombus on this. This is his angiogram. You can see the thrombus just wrapping around. There doesn't seem to be that much on the left side, but his O2 saturation was only 80% on a large amount of oxygen. So what we did is, this was a combination of fragmentation and giving urokinase at the time, and we ended up looking like this. This was back in the day when we used something called an angiojet. Do you ever use angiojet in the lungs? No, don't do that anymore. That's an absolute contraindication. When I turned this on, this is before they said don't do it. When I turned this on, the patient had crushing chest pain and felt he was going to die. You can get all sorts of arrhythmias and problems. The heart does not seem to like, or the pulmonary arteries don't seem to like the pressure pulsations from the angiojet. So now it's what we call a black box warning. Don't you ever do that, But anyway, we just put in an infusion catheter, infused overnight, gave some urokinase to get it more open. After 3 rounds of urokinase, now his oxygen saturation is up to 95%. He's looking better. We continued him on urokinase overnight, and 6 months later, you would never know that he ever had a pulmonary embolism. And the thing that was scary about this case of using lytics is he was only a week post-op from an esophagectomy. But if we didn't do anything, he was going to die. So we did something, and he did very well. 22-year-old female with acute lower extremity pain and swelling. So you get that image and that image. What? Thrombus. So whole IVC is clotted. There's enhancement of the wall. This is acute thrombus. Iliac veins. So most likely, what drug is she on? oral contraceptives. Anyway, she's miserable. Her legs are swollen. What are you going to do? Well, you have to go in and recannulate the vessels and thrombolyse them. We put in a vena cava filter initially and did lysis. And afterwards, most of it was gone. There's the filter at the top. And then we took the filter out, and she did very well. Today, we would not do as much lysis. We would do mostly mechanical thrombectomy using the various systems that are out now. Same one that I showed you earlier for the lung. We would use that and at least debulk the clot, maybe give a little bit of lytic, but in general, we can usually clean this up pretty quickly. Okay, this is something that I used to have to do all the time when I first started out, because we did a lot of things that vascular surgeons do now. This is a person with a right femoral popliteal bypass graft and had acute onset of lower leg pain. So supposedly there is a history of a bypass graft, but you don't see the superficial femoral artery, you don't see the bypass graft, you see the profunda, and there's reconstitution of a very small tibial vessel. So we go in, we find that graft, get in the graft, infuse it with lytics, and by the next day, it usually is now open, and there's the graft hood. And then you have to look for Wyatt stenose. There's the distal graft and the anastomosis. Sometimes they clot for no apparent reason. Sometimes it could be the patient's dehydrated, they cross their legs wrong. It can be a variety of things. Usually there's some stenosis at one of the anastomoses that causes the problem. It's from intimal hyperplasia, and that may have to be dealt with either angioplasty and or atherectomy, or the surgeon going in and doing an endarterectomy and fixing that. Sepsis can certainly be an emergency. How about this case? Gallbladder. People say air. This is not air. Unless you're willing to breathe it, it's not air. This is some type of gas-forming organism. This is actually not air at all. However, this is emphysematous cholecystitis. This is an emergency. These people do not do well if you don't do anything. You can see the inflammation around it, and very rarely do you see one that is like this. You can see the gas so clearly. It's clearly see gas in the wall, gas in the gallbladder on this one. And after drainage, you can see the big stone that's sitting there. Sepsis, again, people can come in. Usually, it's amazing to me, sometimes people can have very large abscesses and you'd never know they were sick. And sometimes you can have very small abscesses and people can be very sick. In this case, there's this collection anterior to the rectum, and that's at an abscess, and it's a simple drainage procedure this is prone patient now. We go transgluteal approach, try to stay below the piriformis muscle to try to minimize the risk of nerve or vascular damage, and we can usually drain these pretty well. Again, sometimes we cause our own problems. So this is a patient had a biliary drainage and had persistent hemophilia and bleeding around the catheter. And especially if you get intermittent bleeding and bright red bleeding, you know there has to be an arterial injury somewhere, and it's frequently something in the tract near the catheter and on the arteriogram. See that little dot? That's a pseudoaneurysm. So that gets just a little dot, but that gets embolized. And again, the same way with the kidney one. If you don't see it, you can't figure out what is the cause. You can take the tube out over a guide wire. A lot of times that will open it up and then let you know exactly what is bleeding. So this one, it was bled, the tube was left in, and the patient did well. So this is doing a nephrostomy. This is the old school method of doing a nephrostomy, where you just did all with fluoro, and you know, the needle's going down on that calyx. You change the oblique. That'll show you how deep you're going to go. You ideally want to hit a calyx directly because the blood vessels are smallest there. When you hit the infundibulum or hit the pelvis, the blood vessels get bigger and bigger. So, and of course, you know, here we go. There's a nephrostomy, access. And after you do it, oops. So here is a large hematoma. And in this case, the tube is in. There is an arteriovenous fistula from the tube. And it never, I'm always amazed that you can stick tubes into kidneys at all. The kidney is one of the most it's almost like the heart. It's one of the most vascular organs in your body. It's all blood vessels. And the fact that we can put tubes, and especially big tubes, and take out stones, and that every patient doesn't die from bleeding surprises me. So when you go and look at a cast of the blood vessels where you inject blue into the veins, blue plastic, or red plastic into the arteries, you get this. And it's amazing to me that you can stick anything through all this into the collecting system, which is yellow, and not cause massive bleeding. But thankfully, the body is very good at stopping bleeding. Sometimes it just isn't quite good enough. So we are actually going to stop here. I have more cases, but they're kind of all the same. And we're back to the same picture of the hospital.